Very good evening to everyone. Today's session topic is indication and types of mandibulectomy in oral squamous cell carcinoma, and what are the options for the reconstruction. Starting with an introduction, mandibular resection has an implication on functional and aesthetic outcomes in oral squamous cell carcinoma. Options of mandibular resection includes marginal or a segmental mandibulectomy. Periosteal stripping is offered to a distinct subset. So before understanding where you have to go for the segmental and marginal mandibulectomy, let's see what all the routes were propagated in the past for tumor entry in the mandibles. There is a multiple theory propagated by different authors in the past, in which one of them is by Marshita et al. In 1971, in which they have said that tumor invades the mandible directly, followed by a McGregor's and McDonald's theory, which is proposed in 1988, in which they have said that tumor enters into the mandible through occlusal surface or through a mandibular foramina. Then in 2002, Brown said that it is entered to the point of abutment. So, point of abutment is the most accepted theory behind mandibular invasion. McGregor's and McDonald's propagated that occlusal route of tumor entry. However, considering that their cohort include a significant number of edentulous mandibles, attrition resulted into decreased vertical height, making it the occlusal surface corresponds to the point of abutment. As we can able to see in this picture, if there's a accretion occur in the edentulous patient, so the point of abutment will eventually becomes the the occlusal surface is eventually becomes the corresponds the points of abutment of the tumor. Next is how we assess the mandible, that how much the tumor is invaded in the mandible. So there is a study by Brown et al. Which is published in 1994, a comparison of different imaging modalities and direct inspection of periosteal stripping in predicting the invasion of mandible by oral squamous cell carcinoma. Their objective to compare different imaging modality and periosteal stripping in predicting bone invasion. The cohort was 35. The imaging in which they have compared this technique were included. They have included were MRI, bone scan, CT, OPG, along with a periosteal stripping for mandibular invasion with histology as a gold standard. Before explaining this article in detail, I would like to make a note. There's another article by Brown et al. In year 2001, in which they have summarized the different imaging modality for their specificity and sensitivity. So, in that they have concluded that combination of sensitive and specific investigation together with intraoperative periosteal stripping will result in the most accurate prediction of invasion. In 1994, they have concluded that the periosteal stripping has the highest specificity compared to the CT scan. So there's another study by there's another Indian study by TMH group, in which they have compared different imaging modalities, which includes OPG, multi-detector CT scans, dental scan, and CT scan, and they found that the equivocal sensitivity and specificity of multi-detector CT scan. So they concluded that MCT scan is fairly accurate in pre-operative assessment of mandibular invasion. Let's see the individual imaging modality in detail. That coming to the OPG, it is a more specific than sensitive with a high false negative rate. So OPG tends to underestimate the actual width of invasion by an average of 13 mm and depth by 2 mm. Other drawback of OPG includes superimposition of the spine in the midline. So the current indication for OPG has an oral prophylaxis and planning of dental rehabilitation. It has a specificity of 81% and sensitivity of 76%. Next is bone scan. It has a sensitive then OPG, but average false negative rate is 3 to 5%. And bone scan overestimate the invasion of the jaw by an average of 14 mm in width and 15 mm in depth. And their specificity include 74% and sensitivity is 93%. So if we consider a bone scan for imaging, preoperative imaging in the mandibular invasion, so we have to be conscious about, we should be cautious when we are taking a dentate mandible, because for higher rate of false positive choices. Next is spexity. It is a combination of functional and anatomical imaging, higher sensitivity and lower specificity, with a sensitivity of 97% and specificity of 76%. So it gives a more high false positive range. Coming to the CT scan, in 1994 article by Browns et al., in that they haven't found a very good result from CT scan. They have concluded that it's because of the different scanner. They have used a different scanner with no fixed protocol, and they further suggested an extensive form of CT scan. However, in 2001 article, they said that it has a specificity of 86% and sensitivity of 75%. So there's an in an article by Chalker et al., which is published by PMH, in which they have said that CT scan is almost equally specific and sensitive, and the multi-detector CT scan has ability to reformate the image, and it can differentiate it, because it has a soft tissue correlation. It is able to differentiate lesion of dental origin or because of the tumor. Next is MRI scan. It is good for marrow infiltration, and it has a false negative rate of 6% with a specificity of 72% and sensitivity of 85%. Next is dental scan. It has a good sensitivity, but because of no soft tissue correlation, it is not a choice for imaging for bone invasion. Now coming to the principle of treatment. It could be either we can go for the periosteal stripping or a marginal mandibulectomy or a segmental mandibulectomy. Now the question is when and where we have to do all this. So in periosteal stripping, it should be the tumor should be away from the point of abutment, that is away from the adjacent and reflected mucosa. Marginal should be considered in when the tumor is abutting the mandible or if it is less than 5 mm invasion. Segmental is considered when there is a gross mandibular invasion. We have to make a note also that in AGCC 8th edition, they have said that superficial erosion of bone and tooth socket alone by a gingival primary is not sufficient to classify as a tumor as a TPO lesion. Now coming to the types of marginal mandibulectomy. It could be a vertical marginal mandibulectomy, horizontal marginal mandibulectomy, and oblique marginal mandibulectomy. We have to make a conus shaped because to reduce the bite force and which can reduce the chances of mandibular fracture. In cases of RMT lesion, we have to include the coronoid process to avoid the post-operative trismus. And other reverse mandibulectomy, in which the inferior border of the mandible is in which the inferior border of the mandible is resected. It happen in the cases like when there's a soft tissue disease such as fixation of perivascular facial lymph node to the lower cortex of the mandible. Now, what all the contraindication to the marginal mandibulectomy? So it could be because of if there's an inadequate stump, that is less than 1 centimeter remaining mandibular height, Next is edentulous and a pipe stem mandible. That is when in edentulous mandible, there is a reduced and vertical height of the mandible, which leads into the pipe stem or a cylindrical mandible. Next is when infiltration is more than 5 mm, and third is that oncological safety is in compromise, that is in post-radiated case. Coming to the segmental mandibulectomy, there is no particular classification given by an author for segmental mandibulectomy. However, anterior mandibulectomy includes the anterior segment, lateral mandibulectomy includes spares the condyle, and in posterior mandibulectomy, it's when we have to include the condyle. There is a classification which was proposed by Joyce et al. In 1989, in which they have segmented different kind of segmental mandibulectomy with denoted as capital letter. So the capital C letter they have used for the central defect, which includes from canine to canine. Lateral they have included if there is we have spare the condyle, and H letter they have used when they have said that it is a heavy mandibulectomy, or when condyle is included. So according to these three letters, they have promoted 8 permutation, which includes anterior segment, lateral segment, hemimandibulectomy, lateral and central segment, hemimandibulectomy, extended hemimandibulectomy, and subtotal hemimandibulectomy and total mandibulectomy. This is another article by Brown et al. In which they have given a guide to mandibular resection for oral squamous cell carcinoma based on Coward and Howell classification of the mandible. So what is Coward and Howell classification? So they have Coward and Howell classify posterior mandible into 3 subcategory. Class 1 and 2 includes a dentate or immediate post-extraction mandible. Class 3 and 4 include if the mandible is greater than 20 mm height or a well-rounded or knife edge ridge. Class 5 and 6 when the mandible height is less than 20 mm or a flat or depressed ridge form. So what Browns and et al. Did is they have used a different imaging modality, and according to this they have classified where to go for the segmental and where to go for the marginal. So if there is OPG, MRI and bone scan along with a clinical examination, all were negative. So in that case, we can still think of in category 3, we can still think of marginal mandibulectomy or a segmental mandibulectomy. Otherwise, if the mandibular height is less than 20 mm, we should go for the segmental mandibulectomy. This is an article by Systemic Review and Meta-Analysis by Gao et al., which is published in 2017. They have included 15 cohort studies, which includes 1,672 participants. They have said that segmental mandibulectomy gave 73% better disease-free survival than marginal mandibulectomy when marrow was embedded. The overall survival was evaluated, and there's no statistically significant difference was found between the 2 different mandibulectomy approaches, although the results showed a trend in favor of segmental mandibulectomy, which could increase the overall survival by 23%. So they suggested a marginal mandibulectomy when there is no invasion or superficial invasion, and segmental when there's an extensive mandibular cortex invasion or medullary invasion. Before starting with the reconstruction option, we have to keep in mind that mandible has a multiple force applied on it, either because of the condyle or a bite force, torsional force, transverse bending force, and sagittal bending force. So according to that, we have to choose our goals and options for reconstruction of mandible. So goals will include re-establishing the shape of the lower third of the face. Second, creating a surface for mastication or dental restoration. Third is preventing deviation of the jaw leading to malocclusion. Fourth is maintaining free movement of TMJ. And fifth is providing a stable wound that does not result in orocutaneous fistula. And options include either we can go for the no reconstruction with primary closure of the oral soft tissue to themselves, reconstruction with metal plates, non-vascularized bone graft, osteomyocutaneous pedicle flaps, soft tissue pedicle or free flaps, and osteocutaneous free flaps. Starting with the no reconstruction or a primary closure or a skin graft, usually performed in a marginal mandibulectomy when enough soft tissue present for primary closure. Split thickness skin graft is not advisable on a raw bone. Next is mandible reconstruction with the reconstruction plate. Popular prior to development of microvascular free bone flaps. It has a high risk of complication, which includes plate fracture and or exposure either intraorally or through the skin of a cheek or chin. And it range complication rates from 21 to 87%. To decrease this rate, many authors combine this plate with a soft tissue reconstruction. So then in series of 80 patient by Y et al., they have reported a complication rate of 69% in patient reconstructed with soft tissue free flaps, plate exposure, soft tissue deficiency, deformity of lateral face, intraoral contracture, trismus, and osteoradionecrosis are the few named complications. And 31% of the patient with complication ultimately underwent a secondary salvage procedure with a fibula osteocutaneous flap. So the for mandibular reconstruction with reconstructive plates is based on case to case, mostly advisable in benign disease. Next is non-vascularized bone graft. So there's a cardinal prerequisite of a successful bone grafting was given. It was first bone transplantation into a healthy tissue. Second is wide contact between adjacent bone and the graft. Third is recipient area with adequate blood supply. And fourth is there should have a positive fixation. That is, there is a particularly space for the fixation of non-vascularized bone graft. So, autogenous bone graft can be used for mandibular reconstruction. Source of cortical bone graft include iliac crest, split calvarium, and ribs. Non-vascular bone graft may be used in defect less than about 5 cm long. High failure rates are frequently seen in longer segment and in interior defects. Metallic mesh or a Dacron tray filled with a cancellous bone chips have also been used for limited defects. Contraindicated for non-vascularized bone graft include artery treated or if there is a planned post-operative radiotherapy, and mostly restricted to the benign disease. This is an article, systemic review paper by Mora et al., in which they have included 25 articles with a cohort of 926 patients of non-vascularized bone mandibular reconstruction. The most frequent donor site was the iliac crest, that is 76%, followed by a ribs, which is 16%, and fibula 5%. Then followed by a calvaria, sternum, and scapular grafts, as well as combination of grafts were also used. Only 11 studies reported the defect site, which range from 1.5 centimeter to 14 centimeter. So majority were benign, and other with 26% were malignant tumor. The use of these grafts has been recommended for defect of up to 6 centimeter. A 75% loss rate was observed in graft of 12 centimeter. And the complication rate was reported was 33% with infection, suture adhesions, graft loss being the most common complication. However, all were manageable. So the conclusion they made that it is contraindicated in malignant tumor and can be used in small lateral defect. Coming to the vascularized flap can be a bone flap or a soft tissue flap. Bone flap is further can be a free flap or pedicle bone flap. Free flap examples include fibula, iliac crest, scapular, radioosteocutaneous free flap, and pedicle bone flap has included PMFC with rib. trapezius with scapula, which has a historical view. Next is soft tissue free flap, which includes ALT, anterolateral thigh flap, radial forearm flap, and ram flap, and along with the PMMC flap. Now, coming to the fibula free fibula flap, it is based on the peroneal artery and vein. So before planning for a fibula, we have to examine both lower extremities and palpate for dorsalis pedis and the posterior tibial pulses preoperatively. When not palpable, additional studies may be required, such as MRI, CTA of lower extremities prior to the performing fibula. Contraindicated include peroneal artery magna and arterial insufficiency or venous status. In this image, we are able to see this is the normal anatomy for a peroneal artery. So, popliteal artery divided into the anterior, posterior, and peroneal artery. So, it could be absent. Anterior tibial artery can be absent. So, in these cases, this is contraindicated for the fibula flap. As we can see, anterior tibial and anterior tibial present, but it's not supplying the foot, and posterior tibial artery is missing. Next is in this absent peroneal artery, which is less than 0.1% chances, and then next is long tibio-peroneal trunk, which is also around 0.1% anatomical variation for lower limb. So for fibula, up to 25 centimeter segment can be harvested. Multiple skin islands can be harvested with the fibular graft, including those based on septocutaneous as well as on musculocutaneous peroneal perforators, supplying as a osteomyocutaneous flap. The advantages of free fibula includes it has a long pedicle, flexible skin island, good length of dense cortical bone, consistent bone shape, minimal donor side morbidity, superior union rate, anti-collapse effectiveness, segmental blood supply, the potential for 2 skin paddles, and ease of harvest with a flap survival rate of up to 95%. And multiple osteotomies can be performed with the fibula flap. Techniques for fibula reconstruction, it could be a bone, it could be only bone or septocutaneous flap. Either double barreling technique can be used, pre-plating and osteotomies can be done, prefabricated plates and cutting system 3D approach can be done, and a cantilever technique can be done. So cantilever fibula reconstruction was done when we have to do the condyle in our resection. So in this, what we do is create a pseudo arthrodesis. The end of the bony flap can be anchored by a suture that extends from fibular periosteum or a hole drill in the bone to cut. I would request, sorry Akshat to interrupt. Fibula, what we do is at the end of the bony flap, we anchored the bony flap by drilling a hole or suturing a fibular periosteum at the end of the pterygoid tendon or a hole drill into the lip of glenoid fossa to minimize drift of the bony flap and out of the TMJ joint. The end of the fibular bone flap is rounded with a cutting burr and fits into the glenoid fossa. Next is iliac crest. It is based on the deep circumflex iliac vessel. It has a reasonable length of on average of 8 to 10 centimeter and appropriate vessel diameter with average of 2 to 3 mm for microsurgical application. It has a robust supply, allow multiple osteotomies, harvested as a full thickness bicortical or as a partial thickness unicortical in which inner cortex were preferred. The natural curved contour of the bone is often considered ideal for lateral mandibular reconstruction. There could be a donor side complication which includes hernia, gait abnormality, which can be minimized by split cortical flap. It is contraindicated in obese patients. Next is scapular free flap. It is based on circumflex scapular artery, as we can able to see in this image. The total of 12 to 14 centimeter harvested from either the lateral or a medial aspect of the scapula, either from the lateral or a medial aspect of the fibula. Scapula. Length of the pedicle can be increased several centimeter by including the more proximal subcapsular vessel. The lateral scapular bone flap was based on vertically oriented parascapular branch of the circumflex scapular artery. Has a shorter vascular pedicle, but it is thicker. This is a shorter, but this could be a thicker. The medial scapular bone flap, based on the horizontal oriented cutaneous scapular branch of the circumflex scapular artery, it is thinner but associated with a longer pedicle and minimal disturbance of teres major and minor muscles and the glenohumeral joint, resulting in less post-operative shoulder stiffness. Another variation is based on the angular artery, which allows the longer pedicle up to 17 centimeter. And the disadvantage of this flap is not enough bone stock for osseointegration in plant placement. Coming to the radial forearm free flap, it is based on the radial artery. Up to 20 centimeter vascular pedicle is available. The flap is thin and pliable and can made sensate by neuropathy of the lateral antebrachial cutaneous nerve to the inferior alveolar nerve. This flap can also be designed as osteocutaneous flap by inclusion of anterior cortex of the radial bone. The disadvantage of osteocutaneous radial flap is that there could be a tender rupture, carpal tunnel syndrome, and a significant motor weakness, radial bone fracture, and chronic hand weakness or pain. Stopped for osteointegration, while the scapula and radial forearm do so less reliably. When to place implant depends on resected lesion was benign or malignant, status of adjacent skin and soft tissue, plans for post-operative radiation, and patient motivation. There's an article by Urgen et al., which they have reported 92% of success rate of endosteal dental implants in vascular right mandibular reconstruction, 86% in post-operative radiotherapy mandible, and 64% in previously irradiated mandibles. This is a systemic review by Brown et al., in which they have published report from 1990 to 2015 with a total cohort of 9,499 mandibular defects, in which majorly reconstructed with the fibula, followed by an iliac crest, then by radial and scapular, serratus anterior and ribs, and metatarsal and 10 lateral arm flaps, including humerus. The failure rate was higher for iliac crest than for fibula, radial and scapular flaps combined. When the condyle was resected, fibular flap were used more often than iliac crest, and both radial and scapular flap. So, fibula has the highest osteotomy, and non-union were seen in the radial forearm flap, scapular flap, then the fibular flap. So, they concluded the fibular flap as the widely used flap for the mandibular reconstruction. Coming to the soft tissue reconstruction, for anterior mandibular defect, if osseous flap are mandatory to provide a sufficient rigidity to prevent the antegum deformity with airway collapse, drooling of saliva, and facial distortion. So, on the contrary, for lateral defects, soft tissue flap alone are useful in specific reconstructive scenarios. Flaps reliably fills the dead space, ensure a watertight closure, and prevent re-entering of intraoral structure in lateral defects. So the option includes for soft tissue reconstruction are ELD flap, PMMC, and rectus abdominis flap. Coming to the reconstruction algorithm, it is based on the where the defect of the mandible is. Either it is could be anterior, lateral, or posterior. If it is anterior defect, so which includes anterior to the first bicuspid, may be involved with the floor. This defect will be because of the floor of the mouth, anterior tongue, lower lip cancer. So if there is a failure in reconstruction of this area, which can lead into the antigum deformity, which is very disfiguring and functionally problematic in terms of mastication, pooling of saliva, loss of oral competence, and even airway support. So double barreling configuration may be desirable in the anterior mandible. Why? Because fibula average height is average width is 17.9 mm in men and 13.1 mm in women, while the mandible height is 33.5 mm in anterior region in male and 31.1 mm in female in anterior region. So to compensate this much height, double barreling configuration is desirable. To avoid to avoid the severe prognathia in edentulous mandible, fibula needs to set back considerably. Uh, uh, So the options include for anterior defect could be a fibula, iliac crest, or a scapular. Next is lateral defect. It include posterior to the canine, spare in a framus and condyle for jaw movement and law fixation. The tumor could be from lateral tongue, floor of the mouth, buccal mucosa, submandibular gland cancers, etc. In this double barrel technique is usually unnecessary because the height of the mandible, posterior height of the mandible in male is 25.7 mm and 24.5 mm in females. If not reconstructed with bone, condyle should be removed to avoid continuous erosion in the oral cavity. More anterior defect, more occlusion and step deformity can result. The option includes fibula, vascularized bone flaps, non-vascularized grafts, soft tissue graft. Coming to the posterior defect, which includes condyle, it can be limited to ramus or extended up to a parasymphysis. The tumor includes RMT area, buccal mucosa, tonsillar, lateral pharyngeal wall cancers, base of the tongue, maxilla, deeply invasive skin cancer, parotid cancer, and temporal bone cancer. So whether a bony or soft tissue reconstruction is utilized, there will be a risk for malocclusion due to loss of condyle and TMJ joint disruption. The option includes ALT, rectus abdominis mycotis flap, PMMC, costochondral graft, fibula, titanium prosthesis. So now I'd like to talk about the mandibular preservation, which this is from ASCO 2023. This is the current treatment strategies and risk stratification for oral carcinoma. There is a study by Lecitra et al. In which this is a phase 3 randomized controlled trial comparing the induction chemotherapy followed by a surgery versus surgery alone. So they have included untreated locally advanced resectable oral squamous cell carcinoma from T2 to T4 T staging and N0 to 2 N staging. The sample size includes 195 patients in which they have they have divided into two arms, either into the induction chemotherapy followed by surgery or only the upfront surgery. The regimen they have used is cisplatin plus fluorescein into 3 cycles in a dose of cisplatin 100 milligram per meter square, 5-fluorouracil 1000 milligram per meter square as 120-hour infusion once every 21 days. So the overall total response rate was 82%, with a complete response rate was 33% and partial response rate was 49%. So they have found that mandibular preservation at 21%, in 21% patient we can save the mandible. That is segmental mandibulectomy performed in 31% in the induction chemotherapy arm versus 52% in the upfront surgery arm. So they concluded that 5-year event-free survival induction chemotherapy arm was 57% versus upfront surgery was 46%. So they don't have found any change in the overall survival in the comparing the induction chemotherapy followed by a surgery alone, but they have found that we can preserve more devoidable surgeries in a induction chemotherapy, so they can preserve mandible in few cases. Next is the study by is phase 2 randomized control trial. They have majorly comparing a induction chemotherapy and C2 to T4 lesion with a cohort of 68. They have included a regimen includes the doxytaxel in a dose of 75 milligram per meter square on a day 1. Cisplatin, 75 milligram per meter square on day 1. 5-fluorouracil in 750 milligram per meter square on day 1 to 5 and once every 21 days. So they have found response rate of 38.2%, complete response was 2.9%, partial was 35.2%. So they have concluded that induction chemotherapy arm has an 3.8 years and disease-free survival was 3.8 year in induction chemotherapy arm, and in upfront surgery it was 3.4 years, with a median overall survival in induction chemotherapy is 41 years and upfront surgery arm was 3.4 years. So the conclusion I like to make from this presentation is that choice of resection depends on the bone of invasion. Multi-detector CT scan is fairly accurate in diagnosis of bone invasion preoperatively. Although there are many options for mandibular reconstruction, vascularized bone flaps are the optimal ones. Thank you.
Very well presented, Akshan.
Thank you, sir.
I would like to just add on or probably add a few pointers here. Is that when you
yes, sir, yes. So you're not audible.
Am I audible now?
Yes, sir. Yes, sir. You're audible. Your voice
now? Yeah. Okay.
Yes.
Yeah. Am I audible now?
Yes, sir. Yes.
Yeah. So basically, what is important is that how do you assess the success of mandibular reconstruction? See, there can be, we have multiple methods to reconstruct the mandible, as you rightly pointed out in your entire presentation. It is essential to understand that we need to really objectively evaluate the success of our mandibular reconstructions. There are data, there's good data even from very reputed centers like MSKCC, that even in spite of doing fibula reconstruction, now imagine it is New York and patients are affording and everything. In spite of that, the amount of dental rehabilitation the patients after fibula reconstruction is also to the tune of less than 20 to 30%. We don't know, we don't have large Indian data on that. Okay. And even in the Brown's paper, if you see the large, if you pool analysis of 9,000 patients, similar pooled analysis are there for other papers are there, in which huge numbers. But we really need to know that how many of these patients we are able to actually give them a dental rehabilitation. Now, dental rehabilitation is just one aspect to look at it. Important is to also know multiple other factors regarding whether there was. Somebody wants to speak?
ठीक है वो तो कैमरा कॉन्शियस बेसिकली है
Dr. Arpit, if you want to speak, you can go ahead.
Varun was continue, please. It was an interruption, I think. Yeah.
Sorry, sir, मेरा mic हो गया.
No problem. My concern is to actually we need to really see a lot of other factors. And one very basic factor to look for the success of mandibular reconstruction is to see for bony union. You check for bony union. You also check for the intercondylar distance. You check for the occlusion. Now, only when all these things actually work, only then we can finally give some rehabilitation. So, it is important that we use reconstruction, provide proper reconstruction for patients. But at the same time, the success of that reconstruction also has to be very objectively assessed. Because otherwise, it just adds to another morbidity at a time. And we need to really choose, as you rightly mentioned, that when you would do a thoracodorsal artery, when would you like to do an iliac crest? And yes, fibula has remained the workhorse for mandibular reconstruction, but it may or may not at times be the only option which we should rely on. So that is one thing which we need to. There is so much of in-depth in understanding the success of a good reconstruction, and the soft tissue defect, and for lateralized defect, what would be better? Okay, would you want to give a cantilever as you were mentioning? Then there are multiple randomized studies going on. Okay, in which they are actually trying to compare all these outcomes with virtual planning versus doing the traditional freehand surgery. So that is also something to really look forward to. That if you have a good virtual planning software and planning which can be done, please use it. I think it will improve the fitness. It will improve the healing. It will improve the bone healing, and overall, I think we will be able to better rehabilitate our patients. So that is one aspect that I would like to focus and urge everyone and the audience in this call to go through. Second is in terms of the oncological safety. Yes, you did quote the meta-analysis, and there are few more meta-analysis. I think one more. I think recently published. But essentially, if you go back to the old Farletto's paper in 2005 for oncology, a very nice paper actually. They discussed all aspects of when we should consider a marginal mandibular. So we have those 5 indications and contraindications. But apart from that, it's important to understand when we embark on a marginal mandibulectomy and when are the relative contraindications for marginal mandibulectomy. So that is one. Without compromising on the oncological outcome, I think you give a very nice description of how the point of abutment and the patterns of mandibular spread and why it is safe sometimes to do a marginal mandibulectomy. So I think all of you all can, if there are any questions or anything for Afshan or for the larger audience, I think we can take it, or anybody else wants to add any comment. Vinay, please go ahead.
Yeah, thank you, Dr. Buran. I just wanted to add few points. Almost everything is covered in the presentation. She has done a lot of work with all the research papers. But only few practical points I wanted to add. Depending on the patient and the surgeon's factors, the reconstruction is
So you're not audible.
Dr. Vinay, you're not audible, I think.
when do we decide whether we should do a soft tissue reconstruction? Nowadays, it's like we are not deciding whether we should give bony reconstruction or not. Now we are deciding whether we should not give bony reconstruction or what, because fibula or any bony reconstruction has become the standard of reconstruction at present. So if we see that intraoperative findings, based on that, whether if we can save the condyle or not, where we can reconstruct with the fibula or posterior mandible, is it required? And the second point is the disease so extensive that it might recur? If we feel that on the table that it is an extensive disease and there is a chance of high chance of recurrence, then we are losing a option of fibula by reconstructing at the primary setting. You can go ahead with some soft tissue reconstruction and go for radiotherapy, and if it doesn't recur within 1 or 2 years, then you can plan a secondary reconstruction. That would be a better option than going ahead with primary reconstruction, bony reconstruction, having a bad disease where we might have to re-resect again and lose that fibula. These are the situations where I would definitely explain the patient's attendants during the surgery itself that there is high chance of recurrence. Should I go ahead with bony reconstruction, or there is a chance of secondary reconstruction which we can go ahead later on? So this is one thing. And the other thing which I wanted to tell was ORN, like post-operative case, implant exposure, osteoid necrosis. These are the issues which we face with bony reconstructions most of the time, because inadvertently we have to use implants, and post-operatively we might face these complications, and it has to be dealt for a very long time. Sometimes we might have to go ahead and re-resect, do a salvage procedure. But there were two studies by Dufresne and by Hirsch. I'll just share those articles later on, where even in ORN cases, when there was a post ORN surgeries, they underwent reconstructions with bony flaps again, and there was no difference in primary reconstruction with bony flaps or reconstruction of ORN, like the soft tissues with the infection of the ORN, or the bony reconstructions. So whenever ORN mandible is removed and reconstructed with a vascularized bony flap, so results were same. So most of the times we think that ORN is there, we should remove and give a soft tissue reconstruction. Nothing like that. We can go ahead with again a vascularized bony reconstruction, and we have to plan the patient properly. These are the 2 points which I wanted to add. That's all.
Yeah, excellent point, Dr. Vinay, and very nicely pointed out that sometimes we are in that eternal conundrum that whether we should spend most of is one conundrum, and that's the clinical dilemma. And then evolved genetic take at different points of time, depending on the situation. Very right pointer. The second point was made very relevant that there are high risks for demand exposure. And it is important that some are defects, the kind of defects we see here, are those what I call here the T20. They know less than T20. So then when you have those kind of disease and an extensive soft tissue reconstruction, the outcomes are fairly okay. You see, the outcomes are fairly okay, but then sometimes we need to use double slabs. Sometimes we need to add a little bit of soft tissue more cover, because fibula itself has a little lesser soft tissue until we are able to get a good amount of skin and subcute. So sometimes you may have to cover it with another flap just to give that extra soft tissue and to protect the post radiotherapy fibrosis and exposure, which generally takes place. Also, maybe as young microvascular surgeons and in a busy microvascular surgeon, what we generally tend to do sometimes is that we pay very precise attention to vascular anastomosis and the basic fibula planning. But when it comes to the final inset and the fixation, we tend to be a little complacent, and that actually affects in the final bone union. So and I really find a very good bone union after a good fibula reconstruction. And so having said that, not to desist the young audience or to not go for a fibula or any that kind of an approach. Even for a lateralized defect, just to update, there is a randomized trial, Dr. Vinay, which is going on at Mumbai. They're trying to evaluate the functional outcomes for a lateralized defect with bony versus the soft tissue. So, but also lateralized defect, there is a slight catch over there. Although lateralized defect, we can do a fibula, and there may be more and more evidence coming to probably provide a bony reconstruction if you can save some amount of the condyle. But the main concern becomes when there is a lot of soft tissue defect around. You've taken the medial pterygoid, you've taken the masseter, and some part of the skin that is required. So then what happens is that end up having a lot of soft tissue defect more than the bone defect. And that is when you would rather go for a soft tissue reconstruction because you don't want the patient to undergo radiotherapy safely. And I think that is the area, gray area where we all take some steps. So all in all, that's all. I think from my side, anybody else or any closing comments, Dr. Vinay and everyone? I think a lot of people joined on the call, and if anybody wants to add anything.